Good evening or afternoon, everyone, depending where you're at. Thank you for taking the time to join me for this 1-hour CE course titled Revolutionizing Composite Dentistry, How Key Fundamentals Lead to Predictable and Consistent Restorations. Just a quick disclaimer. I'd like to thank Plaxmacher and Young Innovations for sponsoring this and allowing me to share some of the information that I've gathered and pass it along, and hopefully it'll shed some light on some areas that some of you may be looking for some light in. So thanks to them. And with that, we'll kind of go ahead and get right into it. A little bit about myself. I've been practicing in a general office for 13 years. I graduated from UIC in Chicago in 2008 and took a job and took over that practice and been there ever since. And when I graduated from UIC, we didn't really have requirements for posterior composites. We had a few for anterior, but it was Mylar strips and that was it. Everything was still kind of coming out and we were trying to figure it out, and it was largely amalgam. And when I got into the real world, things changed pretty quickly. And so it was a quick learning experience, and I took some CE courses and tried to learn what other people were doing and apply that. And I've taken that and used that as my foundation to kind of get where I am today. This is my family, my amazing wife and 3 kiddos. And yeah, let's jump into it. So I've got a lot to discuss today. Some of it we'll touch on briefly. Other areas we'll spend more time on. But there's a lot of variables that go into what we do in posterior and anterior direct composites. And I've found that identifying them, understanding them, and using that to your advantage when scheduling or when performing or treatment planning is very key to make sure you set your expectations and the patient's expectations to the correct level. So you're not feeling like things aren't going well, even when maybe they are. And so there's a lot that goes into that. And we all know that there's just a myriad of variables that we face every single day. And so I'll just kind of go through and focus on a few, kind of broadly touch on a couple, and then really hone in on a few as well. So what I've found over the years is that, quadrant dentistry and just direct composites and things like that, it's really the backbone of what we do. It's kind of the workhorse. It's in demand constantly, and it never goes away. And materials have changed, things have gotten better, and we've gotten more predictable, less sensitivity to the bonding agents, things like that. But we're still having some trouble in some areas, and in efficiency and predictability and things like that. And as I just mentioned before, the key I found is that just understanding the variables and learn how to control. So one thing that I've really found is that every case is different, and I try to treat every case differently, and every case is different for different reasons. So there's 2 major players in this, and one of them is the patient factor, and the other one is the very broad category of restorative factor, and in understanding and identifying what challenges lie in each one of these categories, in the patient and the restorative. Learning how to, identify them and determine how many of them you can handle at once, and so that's going to be important in just really getting things, consistent, predictable, and getting the outcomes that you want, the patient wants. And so first we'll do patient factors. I'm not going to spend a lot of time on this, but I feel that it's something that I kind of drifted away from for a while, and wasn't paying enough attention to, and it bit me. And so I think whether you've been practicing for 30 years or for 30 days, it's important to really take a look at who's in your chair and what's happening. Every person's different, and they have different challenges. I mean, I have some patients that can sit there in the chair for an hour and I can work without them closing, and it's totally fine. Others need to close every 14 seconds. And so knowing how to pick that out through the history of working with them and things like that is going to be key in scheduling them and making sure that you're not setting yourself up for, quote unquote failure, because if that person that has to close every few seconds or, cannot sit or handle it, their jaw anatomy, things like that, or they have trouble getting numb, and you're planning on doing, 4 or 5 semi-difficult restorations in a row, that's a tough hill to climb right off the bat. And even though you got 2 done, you feel disappointed. However, it was a success. So it's important to understand when scheduling and when, assessing situations to take a look at, who the teeth are attached to, and just keep that in mind. And one thing I did want to, mention as well with this is avoid letting patients make the decisions that they have no idea how to make. I've since COVID hit and people's schedules kind of freed up, it didn't matter. Can we do this in 2 appointments? Sure, no problem. Yeah. And now that people are getting busy again, I'm seeing, everything's kind of coming back. Like, how many do I have? 3? Okay, well, I just want to do them all at once because it works for my schedule. However, we're sitting there saying, I don't think you can handle that. So coach them, make them understand, the situation, that the extra visit's going to pay off. So just keep that in mind and remain in control of the situation and make sure that it doesn't end up being a bad experience for them. So that's pretty much it for the patient factor. Just something to keep in mind. Like I said, you can teach a whole slew of courses on that, but I'm going to dive into the restorative factors here. And there's a few different categories, and there are just the basic restorative case variables, prep design variables, and matrix and wedge variables. And those are the 3 that I'm going to focus on today. There are more, as we all know, but I found that these are pretty well overlooked in a lot of places, and I did for a long time. And I found that the devil's in the details, and paying attention to these little things in these categories can really change things for you very, very quickly, and it doesn't require much effort. So basic restorative variable, understand the case. So what's the restorative demand? Things that are going to play a role are the size of the lesions or the failing restoration. Is it a large amalgam already? Are you going to have, trouble controlling the gingival margin and where it goes, sub G or super G? Do they have those kind of like never ending wraparound demineralization, caries areas that you have to chase for what seems forever? And these are things that you need to really pay attention to when planning and setting yourself up to understand what you're getting into and how to prepare for it. And also important in scheduling. And keep in mind, where you're working. We can get people numb much faster on the maxillary than we can on the mandibular. And, if they have a history of having trouble getting numb, just keep all that in mind. So just basic things on the front end here, just to make sure that you're not putting yourself in a situation that you're setting up to fail. Okay. So moving right on to prep design. And what I found with prep design is this is something that I didn't pay attention to much either. I kind of took my amalgam prep skills from school and just dumped them right into composite dentistry and figured it's going to be the same. It's going to be fine. And what I realized over time, actually quickly, but even more time, is that it's not. It's quite different. Even when you're removing existing amalgams, there's a few things that if you do them, it's really important, and it helps you control your marginal integrity, and not having these white lines and having very smooth margins at the end that just polish like glass. But it's also important in helping control the contacts and the general form of the restoration in this area. And so it's something that I started paying more attention to, and just taking a few seconds sometimes, or even a minute at the end of my preps to do a couple of quick things to make sure, and it really pays off. So one big word in composite dentistry ever since I got out was, conservative. And that's great. And it's exactly what we should be doing. And we are, a lot of us are doing it, and staying conservative. However, I do think that sometimes it gets a little too conservative. And in that way, what I see is that I've tried to be ultra conservative and, do these tiny lesions like this before. And what I found is that, when I prep something like this, it becomes difficult to place my matrix and be able to use my tools to restore this. And so I would end up with just kind of weird shapes, and sometimes they would fracture because they weren't deep enough. And I would have trouble polishing this. If I had like a little piece of resin here, it would be a bit nightmarish. And so despite being conservative, I think that it's important to just remember a few basic, concepts of just lightly breaking contacts. And we don't have to go, bonkers like we did, back in the amalgam days and just really sweep that box in and put an undercut down there. You don't have to do all that with bonded dentistry, but it's important to have in the molar area, especially, to have an appropriate depth, because they're put under quite a load back there. And also give your tools room to work, be able to get your matrix bands in here and be able to see what you're doing and use your tools and be able to fit the composite shaping instruments in here and be able to get done what you want to get done. Just so important, the takeaway here is just be realistic. And conservative is great, and it's always the goal, but just make sure that you're being realistic and allowing yourself to get in there and do what you need to do. And, in other preparations on the exact opposite end of the spectrum, we go to failing amalgams, which is what I do largely. So my practice is about 73 years old, and I'm the third dentist to run it. And so I've got patients there that have been coming to see me since they were 5 years old. Or that office, not me. I haven't been around that long. And so I see a wide array of challenges every day. And that's what's really challenged me to hone in my skills for certain situations. Treating a 6-year-old is obviously different than treating an 86-year-old with a massive amalgam. And so I see a lot of failing amalgams, a lot of fractures, things like that I have to restore. And it's always filling first in my office, if possible. But again, realistically, if I see fractures underneath the amalgam, we're crowning it, but I always go filling first and give it a shot. But these larger amalgams really bring some challenges to the table, because we don't have a ton of control of where our margins end, right? We're kind of at the mercy of where that old restoration, where it ended. And then also a lot of times I'll see some broken down enamel right in these areas, right next to the amalgam. It's kind of got that gray hue and it's undercut. And I used to think, all right, I'm going to leave that, and my lesion's going to be a little bit smaller, but then I would see that area, tend to fatigue faster, or fail. And so now I get everything to a nice clean margin. And that's really helped me, keep things from having too much occlusal wear, right off the bat. But these larger amalgams, we have to pay attention to when we're prepping them, is to make sure that all the edges are nice and clean, and that there's no undercut enamel, and try to keep these areas down here rounded. Because a lot of times when I cut into old amalgams, they're very square down in this area. So I take some finishing burrs, and I'll show you how to do that later, just to kind of round everything. And it really makes a huge difference. But this is a challenge, and one that I face daily. And that's what I was just discussing, clean and beveling the enamel. And so there's a difference. Beveling is what I do interproximally. Okay. So you're actually placing a small angle on this edge. Okay. So that's kind of given the composite restoration a bit of a infinity margin, and those look beautiful. I do it a lot in the anterior. And if any of you have taken anterior courses or done that, you'll see that that's always a trick to kind of get the composite to blend in, but it works in the posterior too. And it really helps get real clean margins. And I'll do the beveling on the axial walls in these areas. Now, what I call cleaning is done on the occlusal, because you don't want to bevel the occlusal. I don't want a thin angled piece of composite on my margin. So what I do is I straighten up the burr and just kind of sweep through here. So I haven't cleaned this yet. This one I've cleaned, and this was butted up to a composite that was doing fine. So I left it in place. You can see some amalgam stain under there, but you can see how smooth all these margins are, and how blended everything is. And that helps really lead to a beautiful, smooth restoration with not much finish. And when you do polish it, it's invisible, the margins just kind of melt. And that's a key factor. But this one I left unclean. And these are the things that I was talking about when I'm taking out old amalgams. These areas of kind of like beat up enamel. And they may not seem like much, but just take a flame, and I'll show you. It's a Meisinger flame burr that I use for all of this. And I just straighten it up, and I run it almost at stall speed just to blend all this in. And I didn't think it would make much of a difference, but those few seconds that you do these little things, and it really changes the outcome, really makes them beautiful. And this is the burr right here. It's wonderful. I discovered this a couple of years ago, and it's like my workhorse in the office. I use it for anything from finishing and polishing grooves, down in these areas after I'm done with my composite placement, to finishing subgingival margins on class 5s and, anterior cases, and kind of getting in embrasures and things like that for anteriors. But its key use in my office is taking, these sharp edges and just blending them in. And you don't have to run it super fast. And you don't have to do much. It just takes a couple of seconds. You just kind of angle it in the way that you can control the edge of this burr and just go, up and down the axial walls. I typically don't extend on the gingival margin. I'll make sure it's clean with my burr, my prep burr. But I just kind of take that tip and I put it right in the base of the box and just kind of melt these margins down to make sure they're nice and smooth. So just a quick thing to do for every single class 2 in the posterior, and it makes a huge difference. So on the preparation design factor, I like to move into an extreme part of it, and where it becomes really important, and that is enclosing open contacts. And this is something that I see often enough. And they pop up, they come into hygiene chair, and they're getting food trapped between 14 and 15, or 2 and 3, or 3 and 4. And there's, it's led to a lesion, and they're starting to get blunting papilla. And sometimes there's an older crown next to it. But that space is opened up. And what I used to think was, okay, I'm just going to go in here. I'm just going to clean a conservative, little hole here, and I'm just going to blast it full of material, and everything's going to be fine. And what I found is that that's not necessarily true. It's important to, really develop the restoration within the preparation. And so it's important for us to understand how the restoration is going to finish while we're preparing it. And one of the major things with closing contacts is that we're essentially creating a bigger tooth. Okay. So this is like an occlusal view. I love diagrams. I love drawing things, and I'm a vision, a vision learner. So I like to just present things like this. So this is an occlusal view. So if we have our space between our teeth here, and say we're going to restore the bicuspid, we want to create a larger premolar. Okay. So what we want to do is kind of catch the premolar right here as it's starting to transition, and just continue that over to this area to create a contact point. And what I was used to be doing, and I see this often, is that I would just prep this little tiny box here, and then I would have all this area over here that would be unsupported. And I've tried other systems with injection molding and things like that to just try to just add on to it. And I've had luck with that in anterior, but the posterior is different. I found that the areas along the gingival margin have trouble staying because they're unsupported. And so conservatively, prep these teeth in a way that helps to close these contacts. And it's important to just envision that during the prep phase before you even start restoration. And so that's the same occlusal view, but there's also a lateral view. And so open contacts have, two axes that we have to pay attention to. One's from the occlusal, one's from the lateral, because that's important with our contact point. Is not only is it in this dimension, but it's also in this dimension here. And so we have to make sure we give our prep enough depth gingivally to allow the tooth to continue to emerge up. So if we had just, prepped a very shallow box here and tried to get over, if the restoration looked like this, that's an overhang. There's no way around it. And there's no way that you're going to be able to get this filling over to this tooth without creating that. So it's going to be a flossing problem. Even if you had some flash down here to make it not seem so, then we may see that pluck off. So I take it down and give the tooth in the restoration room to do its job and get up to this point and create a contact area. And so the two axes that I just discussed, this is that same shot clinically. And so I had a patient in with a gap between 14 and 15, and he just kept getting food packed in there. And so this is a shot from the lateral, and you can see how this, these margins were kind of, or the contact point was a bit irregular just because of the shape of the teeth. But for some reason, things moved around. And so when I prepped it, I dropped in. He had a small lesion in this area, nothing crazy. But he did have an existing amalgam here that I swept out prior to doing this, and then I decided to snap some pictures. So I just prepped this box. So you can see I extended the box laterally and gingivally. Okay, so that's going to allow this restoration to start emerging here and come over, touch the tooth for a broad contact area, and come back. And then I've extended it far enough gingivally, not crazy, it's super gingival by plenty, but I've given it room to come up and kiss the tooth and help create a nice solid contact. And so this is with everything in place, the Triodent ring, and I use Garrison matrices a lot for these because they just have a little bit more contour, and I feel like I can get a little more control out of those for these cases. But this is the case immediately after. And one of the key things is that there's nothing that's unsupported here. Everything has a depth to it. The restoration lies within the tooth. And it's done in a way that it comes over and creates a nice, broad, gentle, natural contact. And this is a shot from the lateral view. So you can see my margin ends somewhere down here. It's right in this area, but I gave the restoration room to come up and create a nice occlusal gingival contact area for this tooth. And I was even able to create an incisal or occlusal embrasure with this as well. So keep those things in mind when closing open contacts. It's a lot has to do with the preparation design, and make sure you're giving your restoration room to work and not expecting too much out of it and wondering why the margins are square or like the contact area is not natural looking. It's in the prep design. We'll visit some prep design stuff later, but I'm going to jump into the next phase of this, which is like matrix and wedge. So these are two very, very critical components. The ring is also a critical component, but I've tried them all, and I found that whatever ring you're using, if it's working for you, that's wonderful, because the rings don't hold the secret to success in these areas. They have a key job of stabilization of our matrix, and keeping everything nice and still, but also, creating a bit of separation, especially for adjacent cases and things like that. So whatever ring you're using, that's wonderful. You keep using it. If it's working for you, that's great. Same with restorative material. I'll show you a couple cases that I did, and I use SureFill SDR by Dentsply in the box of all my restorations. It's a low shrink bulk fill, but then I cap it with at least 2 millimeters of Filtech Supreme on the top, and so that way there's no shear issues. So materials and rings are important, but matrix and wedge are super critical, and there's a few things that I overlooked for a long time. And until I discovered this, things were challenging for unknown reasons, in unknown cases, and I would be scratching my head. So I'm just going to go over a few things on matrix bands. I could probably talk an entire hour about this, but we're just going to kind of gently breeze through this. And one of the main things is that height matters. I've spoke with a lot of dentists, a lot of colleague friends, and ask them what they were using, and I would even open my old school Palodent box and see that I was only using the 5.5s. That was it. It was just get the 5.5, get the 5.5. And for some cases it would work beautifully, and others it wouldn't. And I couldn't quite figure out why. I thought, why? My matrix is in, it's the gingival margin sealed. Yeah, I had a little bit of extra matrix on top, but why did it turn out that way? Well, it turns out that these matrix bands are designed to contour the tooth height that you're putting it into. So it's just a very simple thing to keep in mind. Don't be afraid at the beginning when you start. If you're going to go and incorporate this in your practice, you may waste a few. That's fine. It's going to save you hours on the other end. So don't use a matrix band that's too tall. Just because you feel like it's closing the space. These things are contoured specifically for those heights. So it can affect things like your contact point, how much flash you have left over, all those things. So make sure you're taking a moment and choosing the right height. Don't just pick the tallest one. And so here's another lovely sketch. And this is an example of a proper matrix placement, right? So you've got your matrix band in, it's covering your gingival margin by a mile, you're good. And it's just coming up past this marginal ridge point. And that's the key factor, is that you don't want this thing coming up too high. And I'll show you why. Is that when you start to grab these larger matrix bands, they have a little bit of a different contour, especially those matrix bands that are like 6.5s that have those little flat tab on them. They're made to kind of stay at a zero emergence for a second subgingivally and then contour out. So if you're using a 6.5 or even a 5.5, in a lot of cases where you needed a 3.5 or a 4.5, then you're immediately your form to create your contact is skewed. And so if you're looking at some of these cases where you're getting like this little kissing contact, and it's almost like on top of the marginal ridge of the neighbor, it's probably the matrix band height. Because when you go in here, and I used to do it too, I would burnish this thing to high heaven, but still that thing's got a memory, it's going to do what it came to do. And it would leave me with some irregular areas here. And it would also give me this area that I would have trouble polishing to create like an occlusal embrasure. And so just really make sure you're picking your heights properly and really pay attention to that. It'll save you a lot of time. And the other key thing is that contour matters. So there's different styles. And now, when I came out, there was like 2. And now there's a lot. And everyone's got super curves and all these wild things, which are great for the right case, because sometimes you don't need a super curve. Sometimes you have like a flatter profile, a flatter contact area, tighter embrasure, and it's going to be hard to get those really highly contoured matrix bands in there. And I would struggle and I wouldn't know why. It's like, why can't I use this in every case? Well, sometimes the case doesn't call for it. So I keep 2 in my office, Palodent, the original Palodents, which are kind of a flatter, they have a nice built-in marginal ridge, but they have a kind of a flatter contour, and they're still contoured. They're beautiful, but they're not over contoured, and you can kind of manipulate these into tight spaces. And then I keep the Garrison 3Ds, and these are great for example, like the open contact case I showed you earlier, where you have plenty of space to put this, this nicely contoured, nicely shaped matrix band in there. So if you're jamming these, more highly contoured, slightly thicker matrix bands in the back, and you're noticing dents in the matrix right at the contact point, like right in this area, take it out and try something different. Because when you try to burnish that down, it's still going to be irregular. And I've kicked myself 100 times for not taking it out when I should have. I thought, I'm already set up, let's go. And then I wish I hadn't. So just pay attention. You can learn a lot by when you're placing it and how the matrix feels when it goes in. So if it feels nice and smooth and it glides right into position, you've got the right one. If it's right at your marginal ridge, you got the right one. If your marginal ridge on your tooth is all the way down here and this is all above it, and you can barely see over the top of it to restore the mesial of a molar, you could probably use a smaller one, and your results will reflect that. And one way that I do it is I just analyze the radiograph. A lot of it's done on site after the preparation is done. I've kind of learned how to look down there and kind of see how far this tooth is coming over. But if you look at the tooth that you're restoring from the beginning, you can tell what kind of contour it wants. So here's a perfect example, number 3 right here. If you're restoring the distal of 3, this area on the tooth is relatively flat. However, if you're restoring the mesial, this area has a very, very big swale curve to it. And so on this, I would probably put the Palodent stainless steel matrix. On this, I would put the Garrison, the more highly contoured one. And the same for number 4. So teeth have different contours. So keep it in mind when you're selecting your matrix band, because they're not all the same. And on to the major player of composite dentistry that I've learned over the past few years is the wedge. And I'll explain what this device is in a moment. But I've really discovered that wedges are the make or break of what I do and how well it turns out. And it controls a lot of things, and it plays a critical role. And I feel that when I came out, it was, we were using Toffelmeyers with the original Garrison Bitine rings. And everything was about separation and trying to create a contact come hell or high water. And the wedge kind of got lost. And it turned into a polypropylene wedge, a flexible wedge, which is good. We got away from the wooden wedges, but the wooden wedges still have their perks, right? We like some solid body to that. And before I came to this, I was actually just using Wizard wedges with matrix bands and just burnishing. I wasn't using a ring because I had trouble with the wooden wedges working with the rings. But the wedges have kind of been lost in the battle. And they're a key player. We see a lot of our composite restoration failures occur at the gingival margin. And, we're not getting recurrent cavities on the occlusal. We're getting them down in the box. And that's where the wedge does its job. And it's a critical component that we need to start paying a little bit more attention to. And it simplifies a lot of things. So to introduce wedging and what's happening when it's wedging or when we are wedging, I've come up with this diagram. It's called wedge physics. And if anyone has taken any of my other courses, you've seen it before. But it's a quick way to kind of explain what's happening while we're placing wedges in and why in some cases when we get to the wedging step, then things just kind of go wrong. And so there's a key physics rule that for every action, there's an equal and opposite reaction. And when we're placing the wedge, we're transmitting a force through our finger or arm or tweezers on this body, and we're pushing that thing in between the teeth. So when we're pushing that wedge in, it's transferring that force that we're pushing on it to the teeth adjacent to it and also to the papilla. So in this embrasure, and this is just a lateral view of a class 2 prep, is the matrix here. So this is just a solid body wedge. When we're placing it in, there's 3 players. We have the left side, the right side, and the bottom. And the left side and the right side are the adjacent teeth, and the bottom is the papilla, which is a very, very key component. And as long in these situations, when you have enough tooth on the left, enough tooth on the right, it'll win and it'll push the wedge down and seal your margin. But when things don't go that way, when you have a margin that's sunk down here and you don't have a lot of tooth, what happens to this wedge is that this tooth, this vector, this force vector, and this force vector start to win. And we see things like this start to happen. And this is a case that walked into my office about a year ago. And she was having some problems back here. And looking at this, you can actually kind of trace where the wedge was tilted here. You can see that piece of flash followed that matrix band perfectly because this is a deeper restoration and the wedge had nowhere to go. In this case, you've got enough tooth on the left and right, but another issue with wedges when you're restoring adjacents is that they have trouble sealing both teeth at the same time. So you can see here that this wedge chose to tip a little bit into the bicuspid and it shorted this margin. And it left this one open. So you ended up with an overhang here and a short here. Other things that we see, just, little things, but they add up and they add up to failure. And a lot of the failure is occurring down here. And it's not the ring that's doing it down here. It's not the matrix band. It's the wedge. And the wedge is just really, really critical to what we're doing. And it plays a huge role. So I'll show you a diagram of what happens when things aren't ideal. So that original diagram I showed you is when we had enough tooth left and right and it was able to win over the papilla. And I, when I would take courses, is everyone would shudder when they would see a subgingival restoration. Oh, the papilla. And I knew that. I was like, yeah, that's going to be difficult, but I didn't understand why. And these diagrams where the physics of what's happening when we're wedging help me kind of understand that, oh yeah, this thing's pushing up and it really messes things up when we can't move this out of the way. It just really, wreaks havoc on what we're doing. And the depths of these margins that I can't control, and neither can you a lot of the times, is like we have no choice but to go where the cavity is, or where the enamel was fractured, or where the amalgam that's in there now ended. So we're down here whether we like it or not. We got to find a way to fix it. So adjacent lesions like this, they require wedges, like I said, to seal two different margins and two differently contoured teeth. And adjacent lesions can cause the matrix bands. As many of us can know, when we put our matrix bands in there, they look nice, and then we wedge, and then things start to happen. One matrix band gets a dent here, and then we're trying to burnish that out, and then did we push it too far into this one? And the wedge plays a key role in stabilizing this, prior to ring placement and during the whole restoration process. And current wedges struggle with this, is they kind of come in and they kind of bulldoze everything, and push everything around, because the matrix bands are just, they're just tinfoil. And so looking at this diagram, this is the two matrix bands in place. So let's see what happens when we place a wedge in. There's two different scenarios. So in this scenario, and this is what I would see the most often, is that my matrix bands, when I place them in, they would be kissing and everything would look fine. Then I place my wedge in, and I didn't do this for the longest time. I never looked back at the matrix bands and seeing if they were touching each other forever, but I started doing it. And what I realized is that in these deeper lesions, the wedge would actually push up and split my matrix bands. So then I would put the ring on, and I would end up with a light contact. And it's because this wedge is being driven up by the papilla, which creates a gap between your matrix bands. Something to watch out for. And there it is, right here. This was actually done by me about 7 years ago. And I did them simultaneously. And I had a wedge in and thought everything was fine, and it flossed light. And I kept that case because I didn't understand why. I kept the radiograph. I redid this at a later time, and I'll show you the results. But the contours were pretty correct. The gingival margins were sealed, but there's a gap. And this is scenario number 2, is that, and I showed that bite wing earlier, and I'll show it again, is that the wedge is being driven over by tooth number, on the right side, and up by the papilla, and it's causing the wedge to tilt over, and it's denting the matrix here and not sealing it over here. And this ends up with these, these strange, contact areas and embrasures, and strange flossing feelings. And you swear it was sealed when you were in there, but this is actually happening. So pay attention when you're, once your wedge and everything's set up, look at your matrix bands, because that's what your filling is going to look like, is what the matrix bands are doing at this moment. And this is what we saw earlier. It dents, the wedge pushed over here, dented the matrix and kept it open in this spot. And it was more extreme in this area. So I went to town and just started figuring out what's happening under the matrix. And this is kind of what led me to those wedge physics diagram. But I want to show you clinically what's happening under a matrix in these deeper cases. And this is what I was talking about earlier. When we have these wide lesions that go down subgingivally a bit, or even not, when we need our wedge to do something, this is what's happening, is that when we put it in, the wedge wants to go where the force is telling it to go. And I was discussing earlier, the crest of the wedge is right here, okay? And it's pushing, impinging on the premolar, and it's leaving the molar wide open. And the same thing in this area, is that the wedge just wants to tilt over. And here's a lateral view where you can see it a little bit more, how, that margin is unsealed on this tooth, and it's pushing, pushing into this margin. What's more important to understand is that the matrix bands are influenced directly by what's happening with this. So they're tinfoil. So if this matrix band is able to go over here, but this matrix band is being shoved into this tooth, this contour is going to be affected, and so is your contact area. So my solution was to engineer a new wedge. And this is what I've come up with. I call it the Versa wedge. I woke up with this idea about 4 a.m. a few years back, and went down to my office and started splitting wave wedges with a 12 blade. I don't recommend that because my thumb has scars to prove it, but I just started testing the concept. Like, what if it splits? It would give us room to get these wedges in there and allow it to follow two different teeth at the same time. What if it splits? And this is what the VersaWedge does, is that when you place it, the wings on it are free. So they can open and they allow the papilla to pop up in between them. And it gives these wings the ability to stay thin and stay low. And what you can see when you pop it through is that one wing follows one tooth, the other wing follows the other. But it also stays low in the embrasure, and that's allowing the matrix bands to do matrix bands things. There's no crest to the wedge in this area that's impinging on the matrix bands or causing them to want to tilt in either direction. It's just wedging, sealing these gingival margins, and letting everything else do its thing. And this eliminates the high pressures on the matrix, and that's important. So going back to that diagram, this is, or the Dentec example, this is the same situation that I had those other wedges in. And you can see what happens when you place a wedge, a VersaWedge in there, how different it is. So this wing is following this gingival margin all the way through the embrasure, past the line angle on both teeth. And these are differently contoured teeth. You know, the molar doesn't start its turn until about here. The premolar starts its turn about here. And so we need a wedge that can seal both margins without adversely affecting the other or failing to seal the other. But the other thing is that the crest of the wedge here is situated right down the middle of the embrasure space. And that's important, as it's not leaning toward the premolar as we'd seen in the others. And this is a lateral view of that, where you can see the crest of this wedge is just right up Main Street. So it's going to allow your matrix bands to come up and just have their natural form and contour without being disturbed by the wedge. Diagram showing VersaWedge in the same case. And this is what I see a lot, and this is what makes it work, is that it allows these wedge wings to sit down in these areas. So the papilla is coming up in between here, but it's squeezed because it's being pushed on by both wings. So you're not going to have any seeping issues. It's being pushed. But at the same point, the wedge is able to stay low, seal these margins, and allow you to do your thing up here. And this is just a view of VersaWedge versus other wedges. So it's clear what it does, right? It splits, and that's the key component. And so I've placed it in the toughest embrasure with the two most differentiating contours or emergence profiles on the lingual. And you can see that it follows both teeth. And these others have just their ability to stay straight. Unfortunately, doesn't do every time what we need it to do, and especially in non-ideal cases. And just a view laterally, so you can see what I was talking about earlier, the crest of the wedge going up into the embrasure, and that can be fine in some cases, but when you get in these cases where you need your matrix band to do its thing, especially in adjacents, it's important to have a wedge that kind of stays out of its way and leaves it alone. And this is just a quick shot of it clinically. And sometimes I'll place the VersaWedges in and then slide my matrix next to it, depending on the case. That's one way to do it, especially if you have a lot of contour. That's kind of tricky to tuck your matrix band around it. I'll slide the matrices in, maybe pull the wedge out just a little bit, and then slide the matrix down and then push it back in. But this is just kind of shows you how it seals very different gingival margins. This tooth has an S shape. These two teeth are going in two different directions. And you can just see how the wings are following each of those cases. And so just to go over a couple of quick things about this, which make it really interesting. And I discovered this by accident. So when I first said, oh man, this wedge is cool, then I started playing with it. And one of the coolest things is that it's compatible with rings, and it works really well with rings. And the reason is that a lot of my struggles lied within ring placement. And when I would place the ring on the matrix bands, it would disturb everything, right? Like sometimes the ring would slide a little bit and it would pull up my matrix band, or it would kink my matrix band. And that's because we were squeezing a piece of tin foil in between two pretty strong tines. And what the VersaWedge does is one side, you can fit it right over the handle, and the other side, you go right in between the split wings. And this is going to keep pressure off of the matrix band in this area. It's going to put the pressure on the VersaWedge from the ring and allow you to kind of slide that second tine on. And it's going to pull that matrix or the gingival margin shut like a belt around your waist. But it's also going to help prevent slipping of the ring, because the ring is going to engage this in this undercut area and not want to pop up and pop off. And ever since I started doing this, that's become a non-issue. I can even restore the distal of a canine, like a large canine lesion, with a ring, because I can engage that VersaWedge and it won't slip off. But before that, it would just want to pop off all the time. And so this is just, a couple of still images showing the final setup. So right in between the rings, or right in between the split wings, and then the final result here where the ring is pushing on those VersaWedges. And this has a couple of advantages. Like I said, it keeps the pressure off the matrix here, allowing it to do its thing. You can see how the wedge is low, but it's sealing the gingival margin. And it's great for cuspal cases. So if you had a cusp fracture right here in this area, and we all know what happens when we put a ring on that, it just dents it. You can place a VersaWedge and carefully slip your ring right on that little thin piece of tooth over the VersaWedge and stabilize it while you're building it up. And you don't have to do like a two-step process anymore to build a wall over here and then put your ring on. And it's also compatible with Garrison. I show a lot of Triodent. That's what I use a lot in my office, but I also use Nitin by Garrison. This one's pretty cool. It's the V shape. And it's also compatible with the Garrison 3D Fusion, BioClear, anything along those lines. And this is just a shot of it in quadrant setup, and what I was talking about earlier is one of the wedge's major roles that we overlook is that we needed to seal in quadrant dentistry like this. We needed to seal both margins at the same time, and the margins are doing different things. And so being able to have a wedge that splits in half and conquer both teeth at the same time while allowing your matrix bands to do their job and create a contact area for us is imperative. And this is just a clinical case that I've done just to show you. So this is a bicuspid molar situation, matrix bands in place, VersaWedge in place, and you'll have varying degrees of split here. It depends on the embrasure and kind of what's happening here. But then I just pop my ring right on top of it. So what I usually do is I put the pad side that's over the handle, I'll press that against the teeth and keep this side open, and then draw this side in between the split wings. And just let it press and let everything kind of shimmy into position. But you can see how, this section of the wedge in this area, the VersaWedge, is really curving around, sealing this margin shut. Same thing for that molar. So both my margins are completely sealed. It's a non-issue. I'm moving on to restoration. And this is the final result. And this is what I see consistently. These two I restored simultaneously. What I do is I'll restore the distal tooth first and then burnish this matrix band and then restore the mesial, just to make sure I get a nice contact area. There's also a trick that I have, it's on the website, that I can actually, with the VersaWedge on, in this case, after I restore the distal, since the ring is not pushing on the matrix band, you can actually take like a hemostat and you can roll this matrix band out with your ring in place and then restore this tooth. So that way you're just doing one class two at a time. That one takes a little finesse, but it works. Another thing about this is that I always commonly run into, tight embrasure spaces in the posterior, or really wide contact areas, broad contact areas. They're subgingival. They have like an S shape to them, and almost nothing fits in there. Well, this guy, you can just take a pair of scissors and clip off one of these wings, and all of a sudden it's half its thickness. And so this is what I use to go into really, really tight, strange shaped areas for tight embrasures. And it's really effective. And you can still use a ring on it too. In this case, just make sure you cut the side off that's not against your matrix band. And then you can just place the ring on top of it just like you would any other time, but you don't have two wings, you just have one. So this case I've brought up a few times, and this is the result. This is with a Garrison 3D Fusion on the posterior, or on number 19, mesial and distal, and then I put a Palodent on this. So another thing is, don't be afraid to mix your matrix bands. You can use Garrison and Palodent side by side, and that's also really effective. Just a quick tip: don't be afraid to mix them. It's the life changer. But you can see what the VersaWedge did here in this very difficult area. Clean that right up. That's a perfect emergence on this tooth. Very, very happy with that. And then in this area where we had the struggle, where we had the overfill here and in the short margin there, it allowed the matrix band to recreate the difficult gingival contours of two different teeth at the same time. And it led to just really, really nice margins and a beautiful gingival emergence. In this case I showed earlier as well, and the same thing. Nice marginal seals, nice broad contact point from a occlusal gingival aspect, important for success. So there's one case that I want to show. And this is awesome. I read through a lot of magazines and find a lot of cases, and I'm always just seeing what everyone else is doing, and I always have since the day I've been out. And this is not me picking on anyone. I love dentists who show everything that they're doing, because it's important for us to learn and to see. And this doctor did an amazing job. It's an amazing case, but I just want to show how a few key things, the devil's in the details. Take pictures of what you're doing. Don't be afraid to do that, and then go back and evaluate them later. And that really helped me improve what I was doing. So again, this doctor did an amazing job. I just want to show one case and how a few things can change the outcome. So these preps, this was a kind of a deep prep on the distal, the bicuspid, the second bicuspid here, but you can see how these margins, the tooth wasn't flared at the end or beveled. And what it does is your restoration is kind of forced to begin here. And if you would have beveled it a little bit further out here, then your restoration would have picked up with this tooth here, and you would have had an easier contact to establish. But since these margins stop right here, the restoration is going to follow this line right in this area. And that's going to affect the contact point. And it's kind of hard to see because there's saliva there, but you can kind of see what I was talking about. It's more of a straight line. And this doctor got the contact area, as I could see on the image. They were able to burnish it over, but just a quick 20 seconds on this, just to flare that out a little bit more, and it would just totally allow your matrix band to have the contour that you wanted and get a predictable result. So I was doing this for a long time as well, just kind of cleaning, and then we're cavity free. All right, let's roll. But now I always take these things off, and it really helped change my results, just to become way more consistent with less flash and polish on this side. Now, there's another aspect of this, and that I want to discuss, and it's like a sleeping giant, and this is the wedge. Okay, so when you look at the prep, this doc did an amazing job of taking just really good photos here. When you look at the prep from this angle, it's hard to tell how deep it goes, but when you look at it from this angle, you can see that thing dives down toward the lingual. And this is where wedges become difficult to use. And so the doc had a situation here where this entering from the buccal was probably not going to be doable. It wasn't going to seal the gingival margin all the way over here, because the wedge is going to want to be forced in this direction. Okay. But what happens is, when the main body of the wedge is placed into this section here, it deforms your matrix, and you start to get wedge shapes in your composites. Now this case, on the other hand, stayed kind of high. This wedge went under, and I'm going to show you the difference on the radiographs. Again, this is amazing results, but it's just key. It's critical, is that this area here, it's kind of hard to see on here, but you can see how there's a flat area, and then the matrix steps out. There's like a voided area right here, and it's not the clinician's fault. It's the wedge. And the same thing happened in this area here, where the wedge kind of made this emergence straight up and down, because it's a difficult area to wedge, especially as you get more subgingival. And so it's critical to have wedges that are flexible, and that stop this from happening, and create nice contours at the gingival margin for, perfect seals. And then the other case here where the tooth stayed, the margin stayed high, you can see it was unaffected. And that's a perfect example, is that you just drop a millimeter on this, and the rules change, the physics change. So it's important to arm yourself with the proper tools that can help you handle this. Currently, there are one size of VersaWedge, but there are more coming out in July. The one we have now is I would call it like small medium, but we're coming out with a full medium, a large, and an anatomical for furcation cases. And so the medium and large would be sort of for larger areas, maybe elderly patients with some attachment loss, things like that. Those areas get real tough to restore with composite. But in the anatomical can also be effective in those areas. So look for those coming out in July. Quick take home things. Just remember, there's more to Quadrant and any composite than bond, matrix, ring, and polish. It's what we focus on a lot, but make sure we're focusing on the little things, the key fundamentals, the patient, the prep design, the matrix, and the wedge. Keep using your rings, whatever you're using. You don't have to go out and buy brand new systems. Just change and modify a few things that you're doing. And you're already doing a lot of things right. Just modify a couple of these things and you might see a huge difference very, very quickly. And plan properly and make sure you have the right tools. So for more information on anything that I discussed today, you can go to burtonbands.com. There's a contact me. And you can reach out with any questions, clinical, anything. I'm happy to answer them. I'm here. I love what I do. I love to answer questions. So I'm easy to find, and we'll be having some more class 2 lectures in the future. Okay, we've got a few questions here. Is it okay to leave existing resin restorations and not prep them out? It depends. This is from Dr. Ha. It depends on the case. If there's anything wrong with it, I'll take the whole thing out. But I had done that restoration a couple of years back, and that patient had developed a lesion on the distal in the meantime. Maybe we couldn't see it on the bite wing, or maybe I missed it. But in those cases where I know what's on the rest of it, I'll leave it. But I would say 75% of the time, I'm just in situations where I'm taking the whole thing out. And do I charge the close open contacts that you created? No. If it's my fault, I don't do it. If it's anything longer than a year and things moved around, that's nature. But that's up to the clinician, as well. But if I've done something and I did a restoration, 3 weeks ago, there's an open contact, I'm definitely not charging for that. I've always been hesitant to restore neighboring class 2s at the same time, fearing an open contact due to the thickness of 2 matrix veins at the same time. Is it your belief that the force created by the ring compensates this thickness? That is an amazing question, Dr. Suarez. And that is a very, very important area and topic, is that do the rings create enough separation? And I think the short answer to that is no, they do not. And I think that we have to kind of become a little technique sensitive in that situation, because a ring is going to be, is not going to do what we need it to do. And you can visit my website. I have a method for doing that with the VersaWedge, where you can slide 1 matrix out at a time, or do the one restoration and then really burnish that neighbor to make sure you get a contact. But it's definitely a case by case situation. Sometimes I do one at a time. I'll put everything in, restore one, and then slide the matrix out and then put the ring on the other. But yeah, I agree with you. It's definitely a tough area. Do you pre-wedge before prepping the tooth? If so, which wedge do you use? This is Dr. Heiss, looks like. I do pre-wedge. I pre-wedge with the Fender wedges, the purple ones, and they're quite amazing. And I use those regularly, especially so I can just kind of speed through the prep and I don't have to, worry about nicking the adjacent tooth. And then for your class 2 restorations, do you use flowable then packable? I use SureFill SDR, which was in the base of the prep. And that was kind of the more gray material looking on the radiograph. And then I use heated Filtech. I like to use heated Filtech on the top because I can shape it a little bit better and it flows a little bit better. But sometimes I'll snowplow SureFill with that. But I do not use, it is a flowable, but it's more of a bulk fill. And it's a low shrink. Do you have to numb the palatal gingiva to allow more comfort with the VersaWedge? No, the opposite, actually, I found is that since they don't come through and poke and stab, they ride in the sulcus and kind of glide in. And they also give you an area to put your ring on top of the wedge instead of having to hit the gingiva. It's the opposite, but be curious to see what you think. And that's it for the questions. I really appreciate everyone joining us tonight. I thank you. If there's any questions, let me know. I am easily available, and wish everyone a nice summer here. And yeah, have a great evening, and we'll talk soon.